Good morning, Dr. Tuznik.
Good morning.
We'll give it another minute or so and let everyone log in. All right. Well, good morning, everyone. Happy Friday. Welcome to another day of Future of Medicine. A couple of reminders before we get started. Make sure your full name is shown on your Zoom profile so I can take attendance. If you have questions, you can use the chat function or raise your hand and we will call on you. Today we have a challenge. Those that keep their cameras on for the duration of today's program will be entered into a raffle to win a $20 Starbucks gift card. So we'd love to see your faces. So our first speaker is an infectious disease physician at UC Davis Health. She's here to talk to you a little bit about her specialty. So welcome, Dr. Natascha Tuznik.
Hi, and thank you for the introduction. Good morning, everyone, and thanks for joining me on probably what is your summer break. I hope everyone is enjoying. So my name is Natascha Tuznik, and I'm currently, as was stated, an infectious disease physician. So I guess I'll, kind of like I did last year, I'll, as briefly as I can, walk you through the journey of how and why I got here, and then try to leave ample time for questions. If is that okay with the moderators? Yeah, okay. And I will preface this by saying that I went the military route to have them ultimately pay for my medical education. So I definitely can speak to that if you have any questions regarding that. And then in general, just about, how I got to become a physician. So after I graduated high school, I went to undergrad. Back then when I did it, many times the entry requirements for medical school were particularly in biology, but anymore these days, all comers are welcome, anyone, any degrees, philosophy, music, fine arts, you name it. But that is definitely a requirement, is to have at least a bachelor's degree. And then after that, you apply to medical schools. And if you do get into medical school, after that, it's a 4-year long process. And then after 4 years of medical school, you do graduate as a physician, but then you have to go on to further training depending upon what you want to do. So for example, if you want to become a general surgeon, then typically your training after medical school is 5 years. If you want to become an internist, like I did, which is internal medicine, that's 3 years of training. And what do I mean by additional training? So you're still a doctor, but you are either considered an intern or a resident, and you always have an attending physician who's supervising you at all times. And so once you graduate from whatever your chosen residency is, you can then be done and start practicing, or you can choose to subspecialize further in your respective career field. So for example, for me, I did my 3-year internal medicine residency, and then I wanted to subspecialize in infectious diseases. So that was an additional 2 years of training. So when all was said and done, I did 4 years of undergrad, 4 years of med school, and then 5 years of additional training after medical school to get to where I'm at today. And I know that sounds like a very long time, but believe me when I tell you that the days ultimately feel short. I mean, it just kind of flies by. It's amazing. But so that's how that process worked. I know you'll probably have some questions about it, and then just how the military portion was integrated. So I come from a long line of service members on both sides of my family, and at least me personally, I felt a strong sense of sort of country and pride, and I was very excited to potentially join the military as a physician. So the same time as I was looking to matriculate into medical school, and you can do the military route, not just as a physician, but also nursing, pharmacy, veterinary school. They have many different type of career fields now that you can opt to do this. But your choices are the Army, the Air Force, or the Navy. And without going into too much detail, I decided on the Air Force. And I met with a recruiter, and they basically stated, as long as you get into a medical school, and you can get into whatever medical school that you want, and they will pay for it. There's no restrictions there. Then they will pay for my medical education, including, all of the books and things that I need, in addition to a monthly stipend, which will help out, with housing, groceries, that type of thing. And then my commitment in turn, after I'm done with medical school and training, so the training doesn't count as payback, is that when you are, done in whatever career field you choose in medicine, that you pay them back the number of years that they paid for you to go to medical school. So they'll do as short as 2 years, which is half of your medical training, or up to 4, which is your full medical training. I opted for all 4. So when I was done with all of those years of training that I told you about, I then served on active duty on a military base at a hospital for those years that I owed the military back. And then you can choose to stay in longer if you wish, or you can, quote, get out, as they say, once your time has been paid back. And then the really nice thing about it, so there's pluses and minuses to both, is that when I was done with my military service, I did not have $500,000 in medical debt accrued that was, paid for. And when I was working as a physician for the military, paying my time back, yes, they do pay you as well. They do pay you to work. So that was nice. I was able to save up quite a bit of money and buy my first house during that time. So I know that's a lot. That's about, 20 years of my life compressed very quickly. And perhaps I went through it too fast, but I do want to make sure I give ample time for you all to ask questions. I recall last year there were quite a few, so I definitely want to be able to take the time to address those.
So while we're waiting for questions, can you talk a little bit about what an infectious disease doctor does?
Sure. And thank you for the reminder. It's sometimes very easy and quick to forget, when you're in this field, that like everyone knows what this is and what you do. So again, I chose internal medicine as a specialty. And I mean, there's many different types of specialties in medicine. So I mean, many of them end in ologist. So a specialist in some sort of, affliction. So ophthalmology for the eyes. There's general surgery, there's orthopedic surgery, there's psychiatry, there's family medicine, pediatrics, which specializes in children. Internal medicine is an area of medicine that primarily focuses on adults, so anyone aged 18 and up. And typically it's more in the inpatient, meaning in the hospital setting when patients are admitted and are sick. You're the person that will see them there. And then you can remain a general internal medicine specialist, and many of them either end up doing work in the clinic or work in the hospital, or a mix of both. And if you want, you can further subspecialize into some sort of ology. So here's where they all come in. So like cardiology is the heart specialist. So anything and everything that has to do with hearts and heart attacks. And if you want to learn how to do the interventions when people have heart attacks, that's additional training. There's pulmonologists, which are the lung doctors. There's nephrologists, which are the kidney doctors. So you can literally subspecialize in any organ for the most part. I chose infectious diseases. So infectious diseases is not organ specific, it's the whole body. And our specialty is on infections. So anything in the realm of what can cause a human infection and where in the body, that's what we do. You may have heard about us a little bit more after the pandemic hit, which nice is not the right word, but in a sense, people understood kind of who we were and what we did. I think before the pandemic, I got a lot more questions about what an infectious disease specialist was and what we did. I get less of those now, but I still get them. But yeah, I grew up in Germany. I've traveled to almost every continent except for one. It's on my list. And so I've been very fortunate between that and the military. I've traveled to so many places and done lots of mission or humanitarian type work. And I saw many, many different types of infectious diseases, particularly outside of the US, that I just found really fascinating. How literally something as small as a worm can decimate villages And I just really got into it. It just excited me. It fascinated me. And it's just something that I really enjoy doing, trying to help, figure out what's wrong with patients, ultimately, sometimes when another specialist maybe cannot figure it out. And so we don't always succeed at that, but that's oftentimes what we're called in to do in the hospital setting and also in the clinic setting.
We have a question in the chat. Is there a difference between internist and family medicine? Can an internist practice on pediatric patients, or is that on pediatricians and family medicine?
Great question. So the latter portion of what you wrote is correct. So an internist specializes only in adults, so anyone 18 and up. A pediatrician specializes only in children, so 18 and below. And then family medicine kind of does a breadth of all of those things. So family medicine sees newborn babies, children, teenagers, and adults. They're less likely to see much older adults who have multiple medical problems. They generally end up being seen by an internist, which is not to say that a family medicine doctor cannot handle that. But family medicine doctors are sort of the jack of all trades, if you will, because they do see that age range of people that the other specialists do not.
We have a question that came to me about COVID. So what did you do during COVID? Did you take care of patients with COVID?
Yeah, so we did. Then actually, so I work at UC Davis in Sacramento at the medical center, and we had the very first documented COVID patient in the United States who was sick and required hospitalization. And we were basically responsible for, in real time, trying to figure out what to do, how to help. This patient was quite ill. This is published data at this point in time, so it's nothing confidential. But long story short, I don't know if you all are familiar with the medication remdesivir, which ended up being very popular to treat patients who are quite sick with COVID, but we were the first institution who ended up giving that. Unfortunately, it did end up working for the patient, but you don't always luck out that way. But when you're presented with a pandemic like this and something that no one knows anything about, you get asked hundreds of questions, and oftentimes you don't know the answers because no one does. But your job at the end of the day is every single day try to get as much data as you can in conjunction with your regional, your national colleagues, the Center for Disease Control, the NIH, et cetera, and just do your best in real time to figure it out. It's very daunting. It's not something I think a lot of us really bargained for when we signed up for ID, because the last time anything like that happened was the first cases of AIDS back in the late 80s, which now HIV is something that people are living with every day, long, healthy lives. But when that first appeared, no one really knew anything about it, and people were dying from it. So our job is both acutely to try to help patients who are sick, but also when these new things come around is to study them. And the hope is, again, like HIV or even COVID at this point being a great example, figure out in the future how to battle this and prevent patients from becoming sick or dying from these types of different diseases.
Jody.
Yeah, question. Do you
Yes.
typically work in a clinical setting mostly, or do you also work on prevention or on, I guess, spreading the word?
Also a great question. So I think for us, infectious disease doctors, inherently prevention is a big part of what we do. So sorry, dogs. I'm trying to close the door. I should have prefaced that. My apologies. But yeah, so most of us are, well, I mean, I can't speak for the entire infectious disease community, but venture to say the majority of us are very pro vaccination campaigns, because that is very preventative. And a lot of infectious disease doctors who do, for example, HIV care primarily, they are that person's primary care physician. So they're also, helping to deal with their high blood pressure and their diabetes and their high cholesterol if they have things of that nature. So prevention is key for our specialty. I mean, it really is for anyone. But once an affliction or a disease affects somebody, sometimes it's easy to treat and sometimes it's not. And sometimes it's not even curable. And then we do our best to manage those after effects. But and then to answer the first part of your question, an infectious disease doctor, like all of us are different in sort of our sub areas of expertise and how we practice. So for example, I have 17 colleagues. A handful spend half of their time in the lab doing research. Another handful strictly do inpatient or hospital medicine. A couple of them do only outpatient or clinic medicine. And then quite a few of us do a mix of both. Many do research, some do very little. So again, it's nice because you really do get to find sort of your niche and figure out, okay, this is what I'm good at, this is what I can contribute, this is what I like to do, and then sort of, carve out your path in medicine of how you want to contribute to the field and practice your craft.
Sophia.
Following off that question, what does your daily life look like? Like what subspecialty did you pick within infectious disease?
Sure, yeah, thanks for asking. So for me, I probably 75% inpatient, just because it's what I like to do. When I first started this current job that I have, my boss asked me if I wanted to do transplant infectious diseases, which is very daunting because it's on the transplant population. So patients who are very immunosuppressed, and so they're susceptible to a host of other things that, quote unquote, normal immune system patient is not. And so I ended up doing that and liking it quite a bit. So I still do that. I have a traveler's clinic, which I love because I've done so much traveling myself and in the military. It's a clinic where people will come before they go on a trip to literally anywhere on this planet. And we talk about very specialized preventative vaccines or malaria prophylaxis or things of that nature that they can do. And then the rest of my time, I spend on research and education. So I love educating. I'm the associate program director for our fellowship. So those people who want to specialize in infectious disease, myself and one of my colleagues, we're responsible for their entire training and to get them to meet all of their requirements and ultimately get them to become subspecialists and pass their boards. And I've taught some at the medical school at UC Davis as well, just because that's something that I like to do. But again, not everyone does that. It's just very individualized. But since you asked, that's sort of the quick and dirty of how my days typically look.
Yeah, thank you. Okay, yeah, thank you.
Jessica.
So as an infectious disease specialist, are you at risk of being exposed to the disease, and like what are the precautions that you do to prevent that, I suppose?
Great thought. Yes, we definitely are. So in the inpatient setting, we see many patients. So for example, when COVID, it's a little different now, but when COVID first hit, every COVID patient that we had, we would have to wear these specialized masks, either hooded masks or N95, KN95s, a full gown, gloves, the whole works when we would go into the room. And so there's still certain infectious diseases that you might not think of in your everyday that are very prevalent out there still. For example, tuberculosis. Who knew, right? But tuberculosis, there are many people who still have tuberculosis. And so that's an airborne, highly infectious airborne disease. And so when we see patients like that, we have to wear the mask, but maybe not the gown. Or sometimes we see patients nowadays with very drug-resistant infections from, that they brought over from different parts of the world. And so we do the full thing. I mean, we wear the hats, we wear the shoe covers, we do all the things. So there's an entire world called infection prevention, which is sort of an offshoot of infectious diseases, but you don't even necessarily have to study medicine per se, but people who just specialize in this, and they write up these guidelines and recommendations for literally every infection that we know of and how you should enter a patient's room or see a patient in the clinic setting. And then there's also still people who work in the lab, right, directly with some of these agents like smallpox or other potential agents of bioterrorism. And then they have different biohazard levels. I won't get into that in too much detail, but when they study these diseases, some of them are maybe you've seen a movie or read a book where they like decontaminate shower, and then, it takes an hour to get ready to go in, and then they do the whole process on the way out. But the answer is yes, we're definitely at risk, but if we take the right precautions, then the risk is very minimal.
Oh, okay, thank you.
Sophia?
I was just curious also, you mentioned that you like lived or grew up in Germany. How did that fit into your like medical school path?
Yeah, it did and it didn't. So I grew up in Germany. I'm a first generation immigrant with my parents to the United States. My mom was German, and my dad was from the former Yugoslavia. But they they established their lives in the United States, and so I think at the age of about 8, I ended up growing up here and learning English and going to school. And then I ended up going down the path that I described to you, and I chose to stay in the United States system for a couple of reasons. One is because I was already a United States citizen at that point. And I mean, I don't know if this is where you were maybe going, but you could practice medicine anywhere that you want. But you either, you have to be a citizen of that country or have a visa to be in that country. And then conversely, let's say, like for me, I've definitely thought about wanting to go back to Germany. But if I wanted to go back to Germany, I would have to go through the entire German medical system. And this is true conversely. So if somebody's, went to German medical school, wanted to come to the States and practice, oftentimes they make you re-go through your entire training and retake all of your board exams again, which is incredibly painful. It takes a lot of time and money. And it's also time lost for income at that point, because you spend so much time in school and accruing this debt that, at some point you really just have to start paying it off. So most people do not end up doing that. They just sort of pick and choose where they want to learn medicine, where they're going to end up, because it's quite a battle to have to deal with some of these other steps on the way.
Okay, thank you.
Mm-hmm.
Alekia?
I was wondering if there's like any difference between like your specialty and like a pathologist or like an immunologist.
Yeah, so there are differences between all three, actually. So a pathologist, typically at the end of the day, what they end up doing, for the most part, they don't interact with patients, live patients. I'll get to why I say that, but much of their work is underneath a microscope, which is actually really cool. And I thought about doing that at one point in my life. So we do a lot of biopsies of different things in medicine, of skin lesions, of organs, of you name it. At the end of the day, when we can't figure out when something is wrong, as they say in medicine, sort of the gold standard is a biopsy, which sometimes is very easy to get and sometimes is very difficult to get in a patient, like if you wanted a brain biopsy, for example. But ultimately, it's the pathologist who then take those biopsies, do all of the magical things that they do with specialized staining and having multiple people review it to tell you, like, is this a cancer? And then what type, what stage? Is this not a cancer? Is this an infection? And it's incredibly important information for us to have, and we rely on them a lot. In addition, about 15 to 20% of their time is spent doing autopsies. So when a patient or a person is deceased and either an autopsy is requested by law or by the family, then they do the autopsy on the corpse, essentially, and they dissect the patient, all of the organs. I've done a few of these. Look at everything under a microscope, and then, ultimately the goal is to define what they think the cause of death was. An immunologist typically is in the world of medicine, medical specialties anyways. There's an allergist immunologist, so / it's somebody who specializes in allergic diseases. I don't mean to oversimplify that. That's not my area of expertise, but they deal with all things that are immune system triggered, allergic types of reaction. They're incredibly subspecialized, and we also, definitely need them at times. But that said, you can also become an immunologist and just work in a lab. You never have to go to medical school, but you can just, you can study immunology all the way up to get your PhD. And that's all you do is just, study some aspect of immunology in the lab. So there's two different ways that you can go. And then every once in a while, you'll meet somebody who is an MD, PhD. They've done both. They've gotten, 10 years of clinical lab experience and done the whole medical school journey that I was telling you about. So they end up studying for a very, very, very long time. But there are MD, PhD specialists out there as well.
Okay, thank you.
Nikita?
As a infectious disease doctor, what kind of diseases will you I don't know if you answered this, but what kind of diseases would you like? Do you treat it? Do you give surgery in that aspect or no surgery? Just like you give you do a different aspect of it. You do surgery in infectious diseases or like vaccinations?
Yeah, so we as infectious disease physicians, we're not what we call proceduralists. So we don't do any types of surgicals or physical interventions on the patient. Oftentimes when we see patients, they may have an affliction of some kind that requires for example, an orthopedic surgeon if they have a bone infection, and it requires us. So the orthopedic surgeon addresses the issue surgically, and then we address the issue from an antibiotic or antimicrobial standpoint. What do we use? Intravenously or orally? How long do we give it? How do we know if it's working? What things do we look out for? So we don't do any procedures, but we do basically interventions on patients. So a lot of what we do when we see a patient, for example, if they don't know what's wrong with the patient, is we spend a lot of time taking an extensive history on the patient, a thorough physical exam, and then as silly as this sounds, thinking about what could be wrong, which sometimes can take hours per patient. But again, we oftentimes, especially in the inpatient setting, in the hospital setting, we work with multiple other specialists on individual patients because typically their problems are quite complex. As you can imagine, if you have to get admitted to a hospital, it's not something that can be handled at home or even at a clinic. But a majority of what we do is either figure out what's wrong with you, and then how do we treat what is wrong with you. And in terms of treatment, we give recommendations for, like I said, a broad range of antimicrobial types of therapy, or even, it's our job to know when is a surgery indicated, but then we have to speak with the actual surgeon who will do the procedure.
Thank you.
Are there any other questions? I don't have any in the chat.
I'm surprised I didn't get any military questions this year. Last year I got quite a few. That's okay.
All right. Okay. Well, I think we got all of the questions. So thank you so much for being here. We
You're
really
welcome.
appreciate it. And if we have any follow-up questions, we'll let you know.
Yeah, please do. It was my pleasure, and I hope that you all got something out of it. And wish you all a good rest of your summer.
Great. Thank you so much.
Thank you. Bye-bye.
Okay. All right. Well, we're waiting for our next speaker. We're going to take a 2-minute break. So be back here at 10:30. All right. So the next specialty that we're going to hear about is neurology. So Dr. Rochelle Frank focuses on neurology and integrative medicine and is an expert in functional neurologic disorder. So welcome, Dr. Frank.
Hi, thanks, Sam, and hello, everyone. Today, I'll spend a little time just saying a little bit about my path in medicine and then about neurology in general. I'm also going to tell you a little more about some take-homes I just give when I was thinking about all this as I wrote it up. So I went to UC Berkeley for undergrad, and there I was majoring in physics. I look back on my application to college, and I did write I wanted to be a neuro person, and I actually wrote I wanted to be going and becoming like a medical, MD, PhD type research scientist, which surprised me when I looked at it a few years later when I was in college. But my path when I got to college was, I don't like this pre-med stuff. So I just put it aside and really didn't think about it and became a physics major. And I spent 3 years as a physics major, but it kept crawling back in that, I think I want to work with people. So I ended up deciding to go to medical school. I did some of the prereqs, but I had some more to do and found out my last year would be a lot more fun if I did biophysics as a major rather than physics. So I switched and got a minor in physics. But I spent most of my college career in physics directly. I did find that, there was a different mindset, and I was actually told that I was taking the easy way out, which I find really funny now. Anyway, so I then went to medical school. I had taken a year off and was working in a lab in Children's Hospital in LA. And I had a detour, which I'll say a little more about, but I ended up marrying my then 4.5-year boyfriend and having a child and deferring a year of medical school once I got in, and went through medical school with a child. And I'll say a little more about that. I knew from early on I was interested in neuro, and that never changed. The psychiatrist tried to say, hey, why don't you think of us? But I just really always thought in neuro. I had a great mentor. And I applied to residencies in neurology. I did do an internship. Now neurology often is just 4 years straight, and I can mention a little more about that. But I did an internship. We stayed in San Diego that year. My husband had been working, and he wanted to get a master's in public health. So my choices for graduate school, I ended up going to Chapel Hill, which was good for both of us. I then came back and did a fellowship at UC Davis. When I finished, I actually, I haven't said this often, but I thought if I really wanted to work part-time and just wrote letters to all the neurologists, then they most were in private practice, and said, I'd like to join you part-time and Northwest. And I just took the AN list and did that. And then I decided I'd rather be in a fellowship and applied relatively late. When I applied to UC Davis, I said, we've already had someone accept for this year, but let's interview you anyway. And then the person, they couldn't get their visa straightened out. So I ended up being able to go there. And I also had a choice between there and UC San Diego. So I did clinical neurophysiology, which is kind of learning all the procedural parts of neurology, and including sleep and EEG and EMG. And then went into practice at Kaiser for 18 years. And I started negotiating. I wanted to be part-time. I negotiated 90%. And then when I got pregnant with my second child, we waited that whole time for various reasons. I ended up asking if I could be part-time, 60%. And I thought maybe they'd give me 70 or 80. But basically he was my mentor, but he was also my boss. He basically said, well, if we could get somebody to take the time and join us because we were growing, then you can have the part-time. So I literally didn't have a definitive yes when I went out on maternity leave, that when I came back, I would be 60%. But during the time the guy came, I got things like, oh, he bought a house. So I had a good feeling he was going to come. Then I was there for 18 years. And during that time, I really developed some interests that I always had in medical school. I became a communication consultant for a decade, where I was coaching doctors on their communication skills. I taught courses in that. But it was really great to have a doctor teaching a doctor rather than someone else. So it worked very well because I really understood the challenges. I also was on the wellness committee there and started something that I'm now still doing with the SSVMS. And I really appreciate Sam and the whole organization's support. I did it twice this week. I have monthly meetings for what's called Balance groups, and they're groups that discuss the doctor-patient relationship. And I started those. I was supported in getting trained as a leader when I was at Kaiser, and I modified it. This is something I learned along the way, is to modify for what people want, and did these groups, which I can tell people more about if you're interested. But they are a wellness. They're not support groups. They're supportive, but they're a wellness exploring like a case about a challenging sort of psychosocial case. And it really gives people a lot of insights, because we're not problem solving. We're just thinking about what's going on. That just spread like wildfire at Kaiser. It ended up that we rolled it out about 11 sites in the North Valley. I had a great team I worked with. And then it spread to all of Northern California and even to DC and Southern California. And when I left Kaiser, it was still in that mode. So it was very cool that the groups really took off because there was a need. I then was noticing I really always wanted to do a whole person approach to things. So later in my time in Kaiser, I ended up going to a conference they had regionally on what was then called CAM, or Complementary Alternative Medicine. That name, the alternative part, really doesn't work. So we really have moved away from it because it's not alternative. It's really part of care, and not instead of medical care, right? It's in addition. And it's like a lifestyle. It's a whole person approach to things. I'm happy to say more about it. But I learned I could be board certified. So I went and got board certified. And then I got board certified with the latest board. That's more of a formal board in 2016. So I kept in that path. And during that time, I started thinking about going out on my own because I wanted to have a different way of practicing. And I can say more about that because I explored that quite a bit, even though I didn't do it. I ended up going to teach at a new school, California North State, and I was there for 6 academic years. I was the clerkship director. I started a wellness committee for the students. I taught a course that was everything but the scientific core curriculum. So it was ethics, communication, public health, diversity, all of those things. And it became a really cool course that is still happening. And I also, if you ever get a chance, if you're interested in medicine, look for Healer's Art, and I can tell you more about that, but that's a great course that I directed there as well. And I was just working with the students. I was starting to do research, and I think I mentioned this functional neurologic disorder. Because of the kind of work I did in communication and my whole person approach, I saw these people in neurology. And they looked like they had neurologic diseases, but people, they had what they thought was just psychological, and they called it conversion. Or a lot of times I'd write no neurologic diagnosis because I didn't want these people subjected to the stigma of having something we didn't even treat very well, because I knew that the stories of what happened were not good. And it unfortunately still isn't good, but it's so much better. So I kept tracking this, and it got a lot of research in the last 10, 20 years. And I just went to the F&D International Society meeting because it changed the name. We have a lot more science about it. And I naturally became an expert in it. And when I was tracking all this, I talked to I ended up, there's something called Doximity, which is a kind of like social media for docs, LinkedIn for docs. I ignore this completely almost. And I just noticed a message that's from the new chair at UC Davis that said, we're looking in the community, just want to collaborate with people. So I wrote back and said, these are my interests: integrative medicine and functional neurologic disorders. I'm trying to do research with my students. If there's things, I'd love to. And we ended up meeting, and basically she said, we want to start a program in F&D. Do you know anyone who'd be interested? Kind of, now I know her. I think she really did want to ask me, but I had been thinking of going out on my own. So I already had a business plan to start a practice because I really wanted to start it for these people, and have been doing that 2 years now. And I've really enjoyed working with a population that has been stigmatized. If you heard more about it, it's the same people who have things like chronic fatigue and fibromyalgia, but they have actual abnormal movements, seizures, you name a neurologic symptom, weakness, they have it. And but it's completely fascinating to me because I'm very interested in the placebo effect, the mind-body connection. Along the way, I got trained in hypnosis, and I use all these things. And I wanted to share my passions because that's part of what I want you to understand, that, I think is important to know, that I would encourage you to do for whatever you decide in your life. Just a couple personal notes. I mentioned I did get pregnant, and I'd been with my then boyfriend, now husband of 36 years. So we've been together 40 years. And it wasn't expected. It was kind of unusual, but that I was careful. But in any case, you don't need to hear too much information. But I ended up deferring a year and having a daughter who's almost a year old when I started medical school. She's now almost 36, and she's done very well with life. And we had a second child about 12 years later. And my second child had some medical issues and other things, and we decided, my husband decided to leave work when I was when he was about 9, And so we were living off a partial medical salary and made that work. And he's done very well, but you know, it was great to have that extra time for him. So I just want you to know that you can work things out. It doesn't have to be this specific picture that sometimes is told. As far as other roles I had, I'm the chair of the Neurohealth and Integrative Neurology section of the American Academy of Neurology, our national organization. And I've been doing that for the last few years as vice chair and chair. So I can say more about integrative if people are interested. And I've been doing wellness work from Kaiser onward, and I'm very privileged to be on the Wellness, the Joy of Medicine Committee for the Medical Society, as well as I've done work at the ADN and at the places I've been, including now at UC Davis. I'm doing some, I actually have a leadership role, which I really was privileged to get of working on professional development, which I consider real wellness, not just corporate wellness, which I know the medical society is very dedicated to true wellness for people. As far as neurology, it's basically a 4-year training after medical school. There's a year of your general PGY1, which is the internship year classically. That's in a lot of places been folded into a comprehensive 4-year program. It depends where. Some have a 1 and a 3. When I did it, it was almost all 1 and 3. And it was an advantage to me because it gave us an extra year in San Diego, which was good for our family for various reasons. But now I think there's more of the people prefer staying in one place. I was in Chapel Hill, which had a very rigorous top internal medicine program. So I didn't really want the intensity of that with a child. So that was part of it. But there were a lot of reasons I chose to do what I did as far as internship. It's not as competitive in a lot of ways, but it's very reasonable, you know, like kind of like internal medicine or others. Usually it's 2 to 3% of medical school classes that go into it. But I think now, you know, the tradition is that neurology is not treatable. Well, that's just totally not true anymore. I mean, we even are starting to have treatments for Alzheimer's. You know, there's treatments for MS that didn't, you know, there's hardly any when I started, and there's now like 25 approved treatments. It just, there's so many areas. There's so many subspecialties that people go into. They include things like movement disorders, epilepsy, sleep, neuroimmunology, neuro-oncology, things related to neuro-ophthalmology or neuro-otology, which is, you know, dizziness and things like that, headache, sleep. I got the neurophysiology, which was kind of like getting better at all those. Of course, there's child neurology that has all those subspecialties as well. And the field I'm kind of in is neuropsychiatry and integrative neurology. Neuropsychiatry is an actual, has programs, and neuropsychiatry, and you could get double boarded, by the way, that anyone who wants me to ask me about that. But and then the field I'm in is not an official field, but again, it's getting more and more official. That's kind of how it goes. You can have opportunities that are inpatient or outpatient. Yeah, you can do telehealth for people who are raising a family and just want very set hours. There's a big shortage in neurology, so there's always open positions, even in Sacramento. And there's just a lot of opportunities. The main thing I'd say is people don't realize how much power they have. Really, we give away our power and don't realize how much we can negotiate. So that's one of the messages I wanted to tell you. And it's, you know, something I think that anyone who's interested could do. Just to give you a few take-home points, and I really just want to leave a lot of times to hear what you guys want to talk about. You might hear I don't have the typical path. I did some typical things, but I really want to impress, especially, it seems like we have to go the way we're told, but you really can create what you want. What's blown me away is I look back and I had some pretty challenging times of being different than the people around me, but everything I've been interested in has grown tremendously. Wellness, communication, and of course, integrative things, and in neurology, just having a different way of looking has got me to the chair, seeing she's amazing. I have an incredible chair, Amy Brooks Kyle, but she has the ability to see my talents, and I'm actually really valued for these unique skills I have. So I think those areas, those subcultures are growing. And I would say, find your subculture. If you're in medicine and you feel like you really want to see a more holistic approach, a whole person approach, that is growing like crazy. And I think it's good medicine. It will be more what is all medicine in some ways. I don't know, there's so many challenges in healthcare right now, but that is growing, including the VA being one of the biggest places. And I could say a lot about all of these things. Really know that you have value, and it costs a lot to hire a physician. It's like $250,000 or even more and so retention's important, and people, if you really want to do what works for you, I'd say look for programs that do emphasize wellness at whatever stage you're in, and don't just give it lip service. I'm happy to say my department is one of those that really cares about the residents having wellness as much as you can. And there's never really a good time to start kind of allowing yourself to be aware of what your needs are. I know there's times in a medical career you have to put that aside somewhat, or at least focus, but there's a way we get in a mode that we always keep delaying our delayed gratification. I'll do that after I finish training. I'll do that. It just never works. So it's really important to at least have an eye on what's the key things you need always, even if it's a small amount. Just what can you keep alive for yourself? I'd also say if you have any way to avoid debt along the way, being house poor. I see people who are stuck in a job because they have a mortgage, and fortunately we didn't have that happen. But there was some real thought of that. And again, neurologists make a decent living. It's not, it's probably more than primary care, but not, it's not crazy unless you do a more procedurally oriented field. But it's a really decent living, but it's, being part-time all these years, I still could make all the things we want. We even have a cabin in the mountains. We got at the lowest end of the market. So we were very fortunate. But just remember all those limits and what you want to do. But if you can do anything to keep yourself freedom by not having debt, not having obligations, you have to do what you want, it'll give you more freedom. And I really would say those things you're passionate about, find ways, whether it's, all those things I did at Kaiser, I did pretty much on my own time, but it paved the way to all that I have now and all those things I love. So I think that's where I want to end it, and just really open it up to anything you guys want to talk about. So there we go.
I got a question that came directly to me about neuro. So do you become a neurosurgeon? Are you a neurologist first?
Great question. No, neurosurgery is a completely different path, and it's very competitive. What you need to do with neurosurgery, you need to do surgery. You do a surgery internship, which is usually incorporated into your neurosurgery program, and you're basically a surgeon first. Neurosurgery is a really tough field, really important field. And I would just say that if you want to do something like a surgical specialty, some of the toughest, most competitive fields are neurosurgery is one of them. Ophthalmology is another, some of the surgical specialties, head and neck, of course, orthopedics. You want to know early that that's an interest. Believe it or not, when I was, working with the medical students, psychiatry got to be more competitive because it's one of the only fields you can go out on your own. And in that one, I would just make sure you're doing the things that show you really are a dedicated person to psychiatry. It's not quite the same as surgery where you have to do research and all those things. But if you have one of those things on your radar as a popular thing, like a really competitive thing, know what fields, if you get it to medical school, what fields are the ones you're most interested in that could be competitive, because you want to plan for that. If you then go to neurology, you usually can find, you just have to show them you've been interested in neurology. So I just keep that on the radar, but it's not the same as neurosurgery where you have to really gun your entire career to get to there.
Jody.
So instead of surgery, what are you typically doing? Are you handing out medicine, or are you just helping patients other ways of medicine, or are you doing clinical, like labs?
Yeah, great question. So we treat a lot of different disorders. The most common ones are things like headache, epilepsy, neuropathies, stroke, dementia, sometimes, spine issues, like the pinched nerves and those kinds of pains come into neurology, problems with vision, multiple sclerosis. And all of those, what we're doing is often people come to us with symptoms, they have no idea what they have, and we have to figure it out. So there's a lot of neurology that's diagnostic. It's a lot of, where you can't just order a test and know. You really have to kind of figure out what we call where's the lesion. So is the problem from the brain or the spinal cord or the nerves? And you kind of map it out. And one of the things I love about neurology is it's like solving puzzles. So there's really a scientific part of it. Then as far as management can be medicines, especially for things like epilepsy or prevention from stroke. When you talk to someone like me, I think there's more of a whole person approach. So I bring in lifestyle, especially things like headache. Even Parkinson's, exercise is one of the main proven things to slow down the process. So you do manage some of these. Sometimes it's a lot of diagnostic and giving advice to what to do next. Neurosurgery is not that common. We sometimes will get symptoms and find a tumor and then we send them to neurosurgery. But like a stroke, for instance, there might be certain kinds of strokes that need neurosurgical intervention. But most strokes, we just need to get in fast and get preventative treatments as much as we can, and then try to look at what's prevention in the future. Again, medicines can be preventative, but I can tell you diet and exercise is much more important for prevention of stroke if you look at the studies. And that's a whole subject I could talk about. But we do all that. It's really managing certain neurologic disorders, and that can be medicines, that can be other forms of treatment. I hope that answers.
Thank you.
Nikita?
So for brain stroke and as a neurologist, do you take care of it or the neurosurgeon will?
For most strokes, it's neurologists. The only
Okay.
time a neurosurgeon would get involved is the kind of stroke that had often like a bleeding stroke. The other thing is the whole field of neurointerventional, which technically a neurologist could do, but that's usually from radiology. And those are the people that when there's a clogged artery that's acutely clogged, they'll go in and pull the clot out. That's neurointerventional, which is slightly different. So there's kind of three fields that are mainly involved, along with a field I didn't mention, rehabilitation. So there is neuro rehab as well. There's physical medicine, and if you want to do rehab, but there are subspecialists in neuro rehab, which would be after the stroke, how to get better and prevent, optimize damage. But
Thank you.
neurosurgeons don't get involved as much unless there's very major, like if there's swelling of the brain, they have to take out part of the brain kinds of things. That doesn't happen very often.
Okay, thank you.
Yeah.
Does anyone else have any questions?
Yeah.
Sophia.
How you mentioned how you started your family like throughout like the medical school or like training process. How did you find time to like prioritize family and like a newborn when you're going through such active like learning?
Very good question. So, and I've talked to quite a few of the medical students about this because it's a really, when do you do it, family? So I would say a couple things. One is I was fortunate enough to have defer a year, and then I had like 10 months at home with my daughter at almost 11. So that was an added bonus. I then, at that point, it was very unusual. Like I was at UC San Diego, and most of the people, we were in graduate student housing, and most people were like, what do you do with your child during the day? Because they were mothers were of wives of the graduate students weren't working. So I had a combo of some childcare that worked really well, and my husband's amazing. So I really must say I have an amazing husband who's right now with our granddaughter who has some special needs. He's going down a lot for a daughter, and he's so good with children. So that's really part of it is just my husband. But we worked it out. We just kind of found community support. I did have a very specific medical student when I was at training that talked to me, and then she decided, it seems like it's the best time to get pregnant during medical school. And she actually ended up delivering during the OB-GYN unit. And she had a second child at the end, and she was amazing. It's just a matter of working it out with a partner and seeing what really works. I mean, there is a reason to delay, and that's why we did with my son, especially since my husband was doing some of his own education. But looking back, I must say, training took a lot out of me, frankly. And I don't know if I was as good a mother to my second child as I was to my first, because I was still in kind of a different mode. So I don't know the good timing. It's very individualized. But what I can say is there are rules and there are things where people have to follow them. If you have needs, there's things that you can't control. You really have to be a team player, especially in the clinical years. You can't like have special whatever, but you can also figure out how to make everything work. I don't know if that answers. I'm happy to talk to any individual more about that because it's a whole process.
No.
Yeah.
No, that was good. Thank you. I appreciate it.
Any other questions? Okay.
I will say one more thing about what you
Yeah.
asked, which is really some people find it much better to get through training before they attempt this. I just don't want people to think that it's so easy to do afterwards either. It's just like it's always hard. And some people, it is harder in training, but there's ways that you're just less settled, so it's easier to, anyway. But I certainly wouldn't recommend it. Someone took away something I said, like do it during training. No, I wouldn't say that. I'd say it's possible to do during training if that's the right thing for a person.
All right. Well, thank you very much for being on. If we have any additional questions, I'll be in touch.
Okay, great.
And thank you. Have a wonderful rest of your morning, Dr. Frank. Thank you so much.
You're welcome. Okay, bye-bye. Good to meet you all.
Have a good time.
Oh, was there a question? Did I hear something or no? Okay.
No, have a good day.
Thank you. Bye-bye.
All right. So we are waiting. Let's see if our next speaker is on. We'll go ahead and take a 2-minute break. Be back here at 11 o'clock. Hi, Dr. K.
Hey, Sam. How are you?
Good. How are you?
Doing great.
All right. We're just taking a quick break. All right, welcome back, everyone. So our last speaker is going to talk a little bit about how medicine and technology meet. So Dr. Kei Nakagawa is the Director of Innovation for the Digital Co-Lab at UC Davis Health, as well as the Executive Director for the Cloud Innovation Center, also at UC Davis. So welcome, Dr. Kei.
Thanks, Sam. No, really great to be here. I always love doing these. Thank you for SSVMS for also arranging these, because I think it's so important for us to kind of have these dialogues and inspire the next generation around how opportunities around healthcare. So I'll give a little bit of a brief background, because I'm a little bit of a non-traditionalist, and I'm hoping we can also keep this kind of an active conversation more than like a one-way. I know that's a little bit harder, especially over Zoom, but feel free to interrupt over video or like throw questions in the chat. Happy to kind of answer those as we go. I actually didn't think I would be a physician. I was actually really interested in biotech in college after I busted my knee in high school. And I was like, how do we actually, grow organs in the lab or like build bones in the lab instead of like doing surgeries that take like 6 months to recover. So I was like completely more like, I always loved innovation or technology and what it can do, but not necessarily thinking I would go into medicine. But in the work around tissue engineering, I met a lot of surgeons. I was like, oh, this is like pretty cool. But ultimately, I actually realized I wanted to go to somewhere a lot more struggling with like basic healthcare needs. So after college, I actually ditched all of biotech and went to Bangladesh for a year to do public health. And I was like actually working on implementing some micro health insurance programs, basically like super tiny prepaid insurance for pregnant women and rural villagers. And that's when I realized, wow, like I really have no idea what's going on. I like wanted to change the world, but this is like really hard to do. So I came back to the US and worked on policy. So I went to DC, worked in the Congressional Budget Office, which is kind of like the bean counter in Congress, and worked on the Affordable Care Act. Some people call it Obamacare, and a few other legislation before realizing I really wanted to understand how medicine is practiced at the ground level, because like policy can be like super big picture, high level, and you kind of lose some of the understanding of like the real world context of healthcare. And so that's where I came to UC Davis for med school. I applied while I was working in Congress, and I saw UC Davis doing all this cool telemedicine stuff. And this was like way before COVID. This was like 2010. So UC Davis was really ahead of the curve when it came to using technologies like telemedicine. So I was like, this is where, I want to be, to learn how you use technology more to scale healthcare and make it more equitable and accessible. So I went to med school at UC Davis. That's how I got to know SSVMS. And then I caught the entrepreneurial bug, started a company, a startup during medical school, trying to create technology to help explain medicine better to patients. And basically fell in love with that. One thing led to the other, and launched this digital innovation group at UC Davis Health after. And that was basically, about 8-10 years after I, started a company during med school. So I'm only sharing the like kind of Cliff Notes version because I feel like there's just so many ways to navigate your career. And a lot of what I explored, in my own way, like doing what I love and searching for what I would love, really helped me to be in this kind of like weird, I call it weird or uncharacteristic role of getting to do innovation at a health system. I like look back when I was interviewing, and I'm kind of this like weird jack of all trades, because I was somewhat random in my career choices, or it looked random. It was obviously like very like passion and kind of soulfully, spiritually driven, but it really wasn't like a straight shot arrow of a career. But I think it gave me a lot of like contacts from many different industries, many different angles into healthcare that allowed me to bring all that together in this role. And now, we're here in healthcare where, we started by calling it this digital health innovation group, the digital collab, but really like digital health is healthcare now. It used to be worth like acknowledging that digital health is like a new and separate branch from the rest of healthcare. But since COVID and, even afterwards and with like, AI and ChatGPT, I think it's almost not necessary to distinguish digital and digital health and AI from the rest of healthcare because it's just getting so seamlessly infused into everything that we do. And I think that's like really exciting to see that technology is much more integral to everyday healthcare delivery than it was before. And I think in a lot of good ways, like, my passion is not for like us to get care from like AI robots and never see a human. I really want AI and technology to make healthcare a lot more accessible, a lot more equitable, and a lot more human centered, kind of like bring it back to the days where you had your doctor like walking door to door in your neighborhood with their briefcase with stethoscopes and medicines in there, right? Like, how do we recreate that like very personalized experience, but with modern science, modern medicine, technology that allows us to do that in a way that is extremely scalable and also a lot more personalized. So I think there's a lot of really exciting opportunities in healthcare that I'd be happy to share more about, and also because of that, I think we need a lot of different types of brains, minds, and backgrounds coming into medicine. So when I was applying to medical school, I would say at that point, fortunately, it was like about half or slightly more than half were women. And we were starting to see about 30-40% being bio majors, while the rest were like history, English, engineering, like a lot more diversity compared to like, I would say probably 10 years ago, if I applied, 10 years prior to that, it would have been like 80%, 90% biology majors, maybe that 10% being, like engineering, right? And like 70% being women or men. So I think we're like really moving toward a really good direction. But overall, like, I really think that the more diversity we can bring in every single way, like, especially from like an interdisciplinary approach, that's going to be so critical because a lot of the technologies that I'm seeing that we're implementing at UC Davis Health, like AI, like remote patient monitoring, which is like basically Apple Watch and anything more, and other things that are way more complex than Apple Watches, are going to need a lot more than like physicians at the table to making it work. And that's kind of my day-to-day role is like, I'm a physician, but I'm much more like an IT technology kind of role, but I can translate with the physicians. But we also have project managers. We actually go into the community and like learn about what their needs are. Like patients need to be a lot more at the table, right? And when we do user testing too, is like we can't just like user test with just physicians and staff. Like we need to actually have community members test out these products because ultimately we're actually going to use a lot of these technologies outside of the hospital. And I think that's what's really exciting about a lot of the technologies I'm seeing that we're implementing at UC Davis Health, or at least and also evaluating, is that we're looking at remote patient monitoring again, which is like, how do we deliver devices to people's homes so we can monitor them that in a way that we're actually monitoring them in the hospital, right? How do we actually do SMS text messaging in a way that everyone can be engaged with their healthcare? How do we actually deliver care at home in ways that we used to only think would be possible in the hospital? So we call that like care at home. But I think a lot of the care is now getting expanded outside of the four walls of the hospital. And that's where I think the diversity is so key. Because if you think about it, the hospital is probably one of the most controlled environments across any industry, maybe only second to like, clean rooms that they use to make like semiconductors, right? Or other like highly specialized equipment. But in general, the healthcare environment is like a very regulated, very controlled environment, which is by design. Now we're trying to deliver that same care in like a trailer park, a mobile home, for patients that are unhoused, for patients that are living in one-story homes versus two-story homes, those that are in Eureka versus in Sacramento. Like basically like the variability of the environments that we're going to be now delivering care is like exponentially more. And people in medicine aren't necessarily trained to understand those variations. I think it takes a lot of like personal experience. It takes a lot of, empathy and a lot of sociology, right, and anthropology to basically be able to design the right way to deliver care in these extremely varied environments. And that's really what medicine is going to look like, I think, over the next, decade and beyond. And it's going to, so therefore, like, I just see a lot of exciting opportunities that that are going to require all of you to bring your own personal experience and background and passion to really design the right models of care for the whole population. So I'm gonna kind of briefly pause here. That was like a very high level, and I can get into like some more real world examples of stuff that we're doing. But if anybody's got questions, thoughts, comments, feel free to share, video or in chat.
Sophia.
I find your like path and your whole like specialty really interesting, and I'm just curious what part or like I guess subspecialty do you like do on like a daily basis? Like, are you more like answering the hypothetical questions or like coming up with the innovations, or what's like how can one be like involved in like different ways?
Yeah, so I actually don't have a specialty. Because I started a company during med school, I kind of had to decide whether to do residency or kind of double down on not doing residency and doing the startup. So I chose the latter. And it's actually really humbling because most doctors practice with a specialty, right? And I don't have a license to practice because I chose more of this nebulous innovation entrepreneurial route. But in reality, it keeps me humble and curious because I know the foundation, but like I'm constantly learning from everybody, like clinicians and patients and everyone in between, in terms of like what they need, what they're looking for, what their problems are. So often, like a lot of the innovation actually like almost never comes from my brain. It's like me, like just I'm trying to like connect the dots. And medicine is like cool in that way because even if you talk to like a veteran psychiatrist, they'd be like, oh my God, like I've been practicing psychiatry for 20 years, so I know I know this space really well, and I have no idea how to do a surgery, right? And like you'll talk to like a cardiothoracic surgeon who's like, in the OR every day, like, doing transplants or valve replacements, and they'd be like, I, have no idea what like the latest, emergency medicine, ED, like clinical guidelines are. So I think like the fact is like medicine is just so massive that like you're constantly like going deep, and then also like understanding that the rest is also going deep in their own way, and it's like this infinite space that's growing to learn. So for me, like I'm constantly like basically diving deep where there's opportunities. Like so if somebody presents like a problem, like we were just doing this cool project around doing at-home colon cancer screening so that you don't have to get a colonoscopy. You could get like a stool test at home. It's much more convenient, much more like, inclusive and equitable in terms of access. But like I had to like refresh my memory around like, okay, what are the current colon cancer screening like guidelines? What is like Cologuard, which is like the modern, more new way of doing colon cancer screening, and then what is the pros and cons on a clinical level as well as on like a business level. So they're just like always like this kind of always like room to go deep and also broader, which is really exciting. So again, I think curiosity and like being humble is probably the best way to be effective in this kind of role. So great question.
Thank you. I appreciate it.
Sakita.
My question is, you are as like building in technology and medicine. Do you work with biomedical engineers? And also, did you go to medical school, or you just went immediately into like your practice?
Yeah, so I did go to medical school. I went to medical school at UC Davis and graduated with an MD degree, but I didn't do the residency, which is like the training component to get your medical license. And so I kind of joke that I got my residency in entrepreneurship and technology instead, in the context of healthcare. But yeah, so yeah, it's I still am a physician, but in a very unorthodox role from probably a lot of the clinicians that you interact with.
So you're both a family doctor and like and also work with technology and medicine.
Yeah, so I'm not a family doctor because that family medicine would be like one specialty that you would do a residency in. So you could do residency in like emergency medicine, family medicine, psychiatry, surgery, the whole gamut. And that's actually what you do after you get your MD. And in the last year of your MD, you typically apply to residency programs, which are specific to a specialty. So I'm kind of in this perpetual like jack of all trades, master of none state, by not having like a specialty under my belt.
Oh, thank you.
And I think like I don't necessarily promote or encourage one path or the other. There's pros and cons to either, to any of these pathways, but there's a lot that you can do with an MD degree without the day-to-day practice, because I basically spend, often more than 40 hours, like, 50, 60 hours or more all week on thinking about the future and then trying to apply it to today. Like what are the things that we could be doing today with the technology that's available that we're not, and working with the physicians, the nurses, the PAs, the IT teams, like who run the electronic medical record, the cybersecurity team, as well as the business side, like the chief operating officer or the ambulatory operations groups. So I basically work across like the entire healthcare system ecosystem to bring together a holistic plan to implement some of these new technologies.
Thank you.
I wanted to, I have a question. So yesterday, we had some students who visited UC Davis. I'm going to show you a picture. They did something with the Oculus. And they looked at, somebody did a surgery recently, one of the physicians, I wasn't there. They did a surgery recently using virtual reality.
Love it.
Can you talk, do you kind of know what's going on in this picture?
Yeah. So I see like, that's an Oculus, that's an Apple Vision. And then I think that one is more like a HoloLens. I'm not recalling which brand that is that they're actually wearing. But so there's two things that you can do with virtual reality, and this is actually a lot more mixed reality, augmented reality. So like the probably the only one, the Oculus, which is the white one with like the three things, are more virtual reality where you're like not able to see the real world at the same time. And then the Apple Vision Pro, and the one that they're wearing is more augmented reality or mixed reality, where you're able to see the real world in its, actual form while also overlaying the virtual layer to it, right? And Google Glass was like one of the first ones to do that as well. And I think there's two things that we see opportunities here. One is around surgical planning, and then the second one is augmented surgical support. So like the first one, I think, is where I see a lot of opportunity, is that, surgery is like running, a race in the Olympics, right? And you want to make sure that you're performing perfectly when that competition begins, or, when the surgery begins. But there's a lot of practice that you wish you could do on the actual surgery, right? Oftentimes you're mentally preparing, which is like when you're reading up on the patient, you're reading up on, you're looking through their, CT imaging, you're looking at the whole patient and understanding where they are as much as you can, so you have it like instantly, accessible when you're doing the surgery. You can also probably mentally kind of like prepare using your, mind's eye, like how you would go through the surgery. And a lot of surgeons do that. I was actually if I was to do a residency, I was actually looking at going into surgery. So I really have a close heart to the space. And so, yeah, there's a lot that surgeons do today, but they don't really have the tools or the technology to simulate the surgery, because that really just requires you being in the OR. I think a lot of these new technologies with mixed reality is really allowing surgeons to be able to actually simulate the surgery using this augmented reality. So you could, some of them will have like a mannequin even, and then it's synced up with your headset so that you can actually overlay the CT scan on the body, right? So like exactly where it is. You can also almost like, simulate, cutting open the layers and like actually seeing what would be underneath. So I think there's a lot that you can do in the surgical planning space, especially for like certain areas like neurosurgery or pediatric cardiothoracic surgery. These two, like, it's actually really hard to know what you're going to see until you get in there. Pediatric cardiothoracic surgery, like the heart deformities are like hard to fully appreciate on like imaging until you're actually in the operating room and you actually see it, with your own eyes. So I think this kind of technology allows you to get closer and closer to simulating that, before the surgery actually happens. Now, also, like, during the surgery, there's just so much that's happening, and you usually have to, like, you're looking down and you gotta like look up, or you're like listening for your nurse, or you're listening for the monitors to say things, but you often have to like look up. Now, what if you don't have to look up and you can keep focused on what you're doing in the OR at the surgical table, but like you're able to pull up the vital signs in real time. You're able to pull up the CT scan at the right level that you're actually operating on without actually looking up and looking at a monitor, right? So I think there's a lot that you can do in terms of real-time insights and analytics that can be displayed to you without losing focus or breaking eyesight from the actual surgery. So those are some of the ways I think AR, VR, mixed reality is going to help. And then ultimately, I actually, during college, because I was thinking of going into surgery, I actually worked with Berkeley engineers on autonomous robotic surgery. So I would train a surgical robot to how, like, I would do a bunch of sutures and it would like learn. It's basically like machine learning before it was like machine learning and AI. It was called that, but like they would, I would do a bunch of surgery, like sutures, and then the robot surgery would remember it or like would learn from it. And then what's mind blowing is it would be able to do it like 10 times faster. Like I would be able to see it do stuff that was like we actually called it superhuman, because it's like a human would not be able to accurately suture at that speed of, like, imagine like even like double the speed would be like extremely hard for a human to do, and it would just not be necessary, like, worth it to try that, right? but for like a robot, it's like it's equally accurate and precise to do it at 2 times the speed or even 10 times the speed. I don't know if you guys recently saw the Rubik's Cube that I think Hitachi or some one of the Japanese companies like was able to do in like 0.2 seconds, like complete the whole Rubik's Cube and like beat the world record, right? But again, so those are kind of things where I do see, pre-surgical planning or surgical planning in during the surgery analytics, but like there is a future where these technologies will then allow humans to do it remotely or like robots to do autonomous surgery as well. So there's like a lot of exciting opportunities in that whole spectrum.
That's cool. Sophia.
I was just briefly curious. Are there ever concerns that like there could be like misdiagnosis or like telehealth or a robot couldn't fully diagnose a problem or like miss something because they're not face to face or they skim over something? Is it like ever, or is that like not at all?
No. Like really great question, right? And I think this is probably the question, right, that we're struggling with when we try to like implement AI at our health system is like, okay, like how do we know how much to rely on AI versus how much to keep kind of humans in the loop? And for us, the answer is never one or the other, right? Like we see AI as more augmented intelligence rather than artificial intelligence. Like it's going to help doctors not have to stare at a computer screen while they're talking to the patient, right? It's going to help physicians think through complex cases with a computer working with them rather than like telling them what to do. So I do think there's a lot more around collaboration, more so than like replacement. And that's probably like the media loves kind of hyping or dramatizing things. So, obviously they frame it more in like, will, AI replace doctors? But the reality that I see on a day-to-day basis from a health system strategy, our innovation strategy is like, we're never really looking at AI just doing this without a human kind of in the loop monitoring. And I think there's like 2 points on this. One is humans are like, if you really think about the doctor today, it's a mashup of a ton of functions that often could be like 5 different jobs, like with 5 different like actual like people doing those jobs, right? So a physician is usually interviewing to gather information. They're also documenting, right? Like a scribe. They're also gathering information for billing purposes, like a revenue cycle financial analyst. They're also diagnosing, which is a form of prediction, right? Like we're never 100% sure. So it's like, but sometimes like 99.9% sure. But so you're predicting something, which of high likelihood. And then you're also treating and managing the patient, right? Which is like treating is like, okay, what applying the best practice clinical guideline to the prediction of the diagnosis. And then you are decision making using your judgment around like, okay, I think it's 99.5% that it's, asthma. What is the clinical guideline around treating asthma, right? And like applying that and then saying, is this person, what does this person, this specific patient need to be treated the most effectively, which is not just exactly the copy and paste of the clinical guideline, right? Like a more good example of this is like, even if chemo is the right form of treatment for a cancer, would you give chemo to a 95-year-old like you would to a 30-year-old? Right? I think that's like the human judgment that's so important is like 95-year-old, they're probably wanting to not, you might kill them faster by giving them chemo and they're going to potentially risk dying in an ICU, or in the hospital when they might want to pass away more naturally over 6 months or a couple years, right, in their home, right, versus a 30-year-old that wants to have a family someday, right? Like you might want to be more aggressive with the treatment. So like I think there's just so much around like the human judgment. So my point one is it's a mashup of a lot of things, and technology, whether it's AI or others, can actually almost release some of those other functions, because like the real core of medical school and like all the training that you do as a physician is not to like scribe really well, right? Or it's really actually around the ultimate care and management of the patient. So if something is able to predict something for you really well, that's also almost okay for something to predict for you, right? And it might give you 5 predictions, like 99.9% it's A, 95% it's B, 72% it's C. You make the call on like based on that, like how you might want to manage it based on this human in front of you, right? So that's like my first point around like, I think there's a lot around the human being playing a key role in the judgment and the compassion and the empathy, which is like, I think could be way more of a proportion of what the clinician and the physicians do, which is getting completely overwhelmed by all these other functions. The second point is I see a lot of really exciting opportunity as we deconstruct all these like functions of a physician, right? It's like there's a really exciting opportunity to allow a lot of other very smart, capable people who are trained to do some of these other functions, right? So we're seeing a lot of like, nurse practitioners, physician assistants being able to take on more responsibility so that the physician can focus on, the things that you really got trained to do over like 4 years of medical school and 4 to 10 years of training, right? Like the physicians by far get more training than any other clinician, right? And how do you leverage effectively that level of training and education for the things that you need it the most, right? So I think that's like another exciting kind of shift I'm seeing, is that again, it's very human centered. It's just that how do we get more humans to help out with a lot of these functions, right? And how do we keep humans in the loop but make it like much more scalable?
Okay, thank you. That was a really great answer. Thanks.
So I can jump into like, I love talking about health equity and digital health equity, because I think this is really very relevant. In the work that we do, the mission that we focus on at UC Davis, and also the future of medicine, is that as we get more and more technology centered, we also risk a lot of patients getting less access than more. And before COVID, this thesis wasn't really tested, but like there was kind of an assumption, even with like telemedicine being one of the first examples like that, the more we use technology, the more accessible healthcare can get, because in theory you can deliver care to places that you couldn't necessarily reach, physically. You basically can create like a much more accessible and equitable system of care. But like if you look in during COVID-19, like it was actually the opposite, right? Like the digital divide got wider. A lot of patients who were already underserved got more underserved because they didn't have a 5G smartphone to do telemedicine. And all of a sudden, it was actually less safe to go to the hospital. So they were like hesitant to even go to the emergency room or the hospital to get care. And so they're actually getting less care, right? So if you're passive with how technology is going to address our healthcare gaps, I think that a more laissez-faire approach will actually lead to more disparities than less, right? And I think there needs to be a really big push to be very intentional with how we deliver care with technology, thinking about digital health equity as like a key part of the consideration. And so some of the work that I've done at UC Davis Health and at the national level is ask the question, like, what does health equity and digital health equity even mean? Like, how do we actually action something like digital health equity when it sounds more like a mission or a philosophy, more so than like a tactical, actionable set of steps? And I've actually, in my role, I work a lot with like startups and big tech companies like Amazon and others, Microsoft. And everyone actually is very, I think, pretty genuinely interested in being like in investing in more digital equity and like tech equity. But especially like startups like don't have that many resources and they don't really even know what that means. So one of the work that I've been doing is how do you deconstruct digital health equity into more actionable components? And that framework we call digital determinants of health. I didn't make up this term, but it's relatively new concept. Digital determinants of health. You might have heard of social determinants of health. So, social determinants of health is actually the more holistic like aspects of care beyond the traditional medical care. And so social determinants of health is a pretty mature concept over the last 20 years that includes like we should be looking at housing, we should be looking at transportation, we should be looking at food and food security. So like that has been something that people have really started to embrace. But digital determinants of health is like kind of this new extension of social determinants of health, because nowadays, like if you don't have a phone or a smartphone or reliable 4G, 5G, then you really don't get a lot of the care that's available to you that you're eligible for. And so we need to start looking at this more a framework around what are the digital determinants or digital drivers of receiving and accessing care. We've defined this, and a paper is coming out, a white paper in the next, like sometime this month or early next, but it's like, we broke it down into like digital connectivity, right? And we nuances to SMS text message level, like basic 3G, 4G level to 5G level access, right? Like what kind of like connectivity do you have? We also address literacy. So like, even if you have the connectivity, if you don't understand what the heck you're looking at or how you open an app or use an app, or understand the content being delivered through the app, then you're also kind of equally at a loss. So we look at like digital literacy, like your literacy with technology, and digital health literacy, your literacy around digital health information, right? Whether that's like through the web and now like ChatGPT. We also look at like digital empowerment. So it's like how much do you feel empowered to use technology? Because sometimes people like just feel like they don't know how to use it and they just like give up, right? So even if they have the digital literacy and the digital connectivity, if they don't feel like they can do it, then they actually aren't going to do it. And then one of the last ones is digital trust. Is like, we saw a lot of trust being a key part of whether you even use a technology, and that could be, technologies like the vaccine, like Moderna's vaccine, let's say, all the way to an app that your physician might have recommended and everything in between, right? So there's like all these really interesting components that we need to really dig deeper into and understand, because if we don't address the digital determinants of health, we really can't move the needle on making healthcare a lot more equitable, accessible, and inclusive. So one project that we're actually using this framework is around the inmate population. So there's a subset of inmates at Sac County Jail who have severe mental illness, which is a very strict criteria, clinical criteria for what it means to be having severe mental illness. Oftentimes, these patients, along with the general inmate population, get released at like random hours of the day. Like, like when I was visiting the Sac County Jail, there's literally like a sign at the check-in where they're like, we do not guarantee when you're going to get released. There's no scheduling, right? Like I took a photo of it. It was like, so some of these patients get released at like 2 a.m., 3 a.m. in the morning, right? And if you have severe mental illness with no phone and nobody to go to once you're released, like what are you going to do? So we have a program where we partner with Sacramento County Jail, the UC Davis Health Psychiatry Department, Wellspace Health, which is a federally qualified safety net hospital, and Verizon to create we created a digital inclusion program where inmates with severe mental illness, when they get released, get a free smartphone with 1 year of free 5G. We preload it with certain apps that would be like kind of already when they turn on the phone, it's like at a finger, just like a one click away. And then we connect them with a case manager from the safety net hospital, who then also is able to text message them or communicate via this free phone that they have to be like, hey, let's check in, make sure that you're using the social services that you're eligible for, right? So it really creates this whole network of people and technology driven solutions that make it where this one of the most vulnerable patient populations have the support that they need, that they're already eligible for, right? Like the whole county and the public system actually have a lot of services for them, but we're not doing the like bridging of a patient that is really struggling mentally and socially to getting them the services that we've already funded as society, as a public system. And we're trying to like kind of close that gap. So a lot of like really kind of novel things that we do at UC Davis Health, and partnering with a lot of the community to bring a lot of this to make it possible. So I'll pause to see if anybody's got any questions around digital equity, anything else that you guys might have thoughts on. Don't be shy.
Anyone have any questions? That's very cool. I had no idea a program like that existed.
Yeah, and I'm happy to answer any career questions as well. I'm happy to like kind of give more examples of the work that we do, but always like to give some time.
We chat. Are you involved in robotics?
Not directly right now. We do a lot of surgical robotics in the OR, right? So Intuitive Surgical is the company, Da Vinci is their product. So more and more physicians are doing robotics in the OR. And then, I see a second question. Do you travel often? So I'll combine it with, and one of the things that we're looking at actually is more around exoskeletons and robotics for aging populations, and also improving patient safety, because I think a lot of the safety concerns actually arise when they get discharged from the hospital. It's like we have a lot of oversight over our patients, when they're in the hospital, literally, like even when they're walking down the hallway, like we have an eye on them. So a lot of the safety concerns actually skyrocket when they get discharged, because now they're in the home and we don't get to see them or monitor them. So we're also looking at some exoskeleton applications, and that's where like I do travel a lot. I get to go to a lot of really cool conferences and around innovation all throughout, like Austin, Vegas, Orlando, Chicago, or like some of the common places where we have conferences. And I network pretty regularly with industry, because that's where a lot of the innovations are birthed. But I'm actually going to Japan in November as a study tour with a group of US healthcare leaders. And one of those visits is going to be with Cyberdyne, which is a AI robotics exoskeleton company that they're doing for kind of seniors in Japan. And so we're exploring definitely more and more robotics for caregiving and patient support at the home, which is just got a very different type of robotic technology than what we use in the operating room.
Anyone
So
else?
how many of you guys use like ChatGPT or some form of Gen AI?
Show of hands.
I don't have a full view, but I only saw like one hand go up.
We
Oh,
got
there we go.
three
Three
hands.
hands.
Yeah.
I was expecting to see like 30. So you're all being shy or coy about it, or being but yeah, like one of the things I do want to talk about, which is very top of mind for us, is how we reliably use AI, specifically large language models and Gen AI. We've been working with and dealing with AI applications for quite some time, but large language models and Gen AI seem to be a slightly different beast from other AI applications. And the best way for me to characterize why we think it's slightly, or why it's meaningfully different, is in the way that it can evolve. A lot of the AI that we were working on prior, like with computer vision, where you can look at like a histology slide in pathology or a radiology image and identify, like suspicious lung nodules. Those algorithms had very set metrics around accuracy. It was like sensitivity, specificity, area under the curve, AUC is another one. But basically, it's like if a company or a professor was like, hey, I trained a model, the faculty might be like, I want to try this out on my patients, or a company will be like, hey, we want to sell you this model that we're pretty confident is going to help you identify, more suspicious lung cancer nodules earlier that you might be missing. We could run it through some pretty established kind of metrics to put it through the gauntlet to see if it's accurate enough for us to consider using. And once it meets the sniff test, we would then deploy it and start using it, right? And we would kind of monitor its performance. But overall, like what you saw and what you evaluated is kind of how it would perform until you update the algorithm. One of the things that's very different with like large language models and Gen AI is that there's a lot more opportunity for it to change and shift after you are using it, because it's a very interactive technology, right? So it's like whether you prompt engineer it or you're just kind of like chatting with it and it's like learning what context you're trying to do something with, and it'll like kind of adapt those responses. You can, as it's a much more interactive AI technology, I would say, and it's going to try to adapt to you. That adaptation could be really great because that might be personalization, right? But it also, kind of the other side of that coin, is it could be more biased, right, than you saw when you first evaluated it to consider using for the health system. Hallucination is also somewhat unpredictable, like when it would happen. And there's also a lot of model drift, right, with the interaction. And so that's like really a pretty interesting and headachy problem, because we usually spend a lot of effort before we decide whether to use it or not. But now we have to spend that same level of effort potentially even after we decided. We have to continuously decide whether we're going to keep using it, and what team resources, financial or people or technology, do we need to have in order to be able to do this in a very responsible way, right? Like, how do we trust the technology that we're using at any given point in time? And the post implementation challenges are actually quite large. And that's an area that if any of you are interested in, and it gets kind of like a nice intersection of technology, healthcare, operations, and even ethics, right? Because we want to make sure that a lot of the large language models that we might use aren't going to hallucinate, And it's also gonna, if we actually offer it to patients so that patients can talk to it as like kind of a first point of contact, let's say, before we connect them to humans, we definitely want to make sure that it's doing a responsible job of interacting with the patients. So I think I definitely encourage all of you to use, whether it's ChatGPT, Perplexity is like the search engine that is pretty common, being used now, and all the open source models that if you guys are engineers, you could kind of play around with even more. Um, I think this is going to be a pretty fundamental shift in how we function as a society and even in healthcare. And the more familiar you can be with it and its quirks, I think the more opportunity is for you all to be ahead of the curve and understanding, where the benefits, where the potential threats that we need to be countering around. And, it's personally like a very exciting area, just because it's so dynamic. And I talk to like national leaders, and they're still trying to figure out how to manage these technologies. So it's a very new area that's going to be ripe for careers and innovative opportunities.
I got a question in the chat. Are there any specific skills or experiences do you recommend gaining early on to pursue in healthcare with technology?
Yeah, I mean, I see like the best people who are able to manage these as people who have really lived their life and experiences to the full. Like it's really not about the technology as much as how that technology is used in real world. And I think if you're kind of just like directed in your life and career without really like living the life that you're meant to live, I feel like it's almost like too manicured of a life. Like, let's say, like, a lot of pre-meds like live in the library, right? And you don't like fully experience like college, and all of a sudden like you're missing out on a lot of these like really important human interactions, because you're studying all the time. I mean, you really do need to study a lot in college as well, especially if you want to go to med school. But like, it's so important to like live life in its full, because a lot of the technologies, and the potential like um, dangers of these technologies are in context to like the full life of a human being, right? Patient and like that patient's entire life. So I think it's people who can really relate their own personal experiences with real stories, right? There's that like intuitive conviction that I feel makes it really convincing and very poignant for the group, right? So I think that's like one of the most important things, is like to be really human and live your life. Also having fun. Like I think the people who have like kind of played with technology out of like genuine interest, right? Not because like you feel STEM is like important and so you learn coding because it's like a strategic decision, right? But more like you played and tinkered with technology because you think it's fun and cool, right? That natural, I think, interest and curiosity leads to a lot of like deeper exploration, which then again is like kind of that genuine curiosity that gives you so much more perspective and insight than kind of like going through a coding boot camp, right? I think that's also something really important. So yeah, like I think my 2 points on, summarizing is like live your life to the fullest, try to understand humans and our very quirky and unpredictable behaviors. And 3, if technology is your thing, go deep, like impractically deep. It's not about a boot camp or a quiz or a project, it's about your creation, right? And your passion that like really drives that next level of understanding. And I think if you do those 3 things, I think you're going to be in a really great and unique position to make an impact in this space.
Awesome. Are there any other questions? All right. Well, if anyone has any other questions for Dr. K, I will get in touch and share those with him. Thank you so much for being here. That's such a great, this is always my favorite. I love hearing about all the different technologies and you know, I know it can be scary sometimes, you know, thinking our robot's going to take over, but you know, no, they're not. So that's the lesson I get from you. No, they're not.
No, they're gonna help us a lot.
Yeah.
And we need a lot of smart people to help to design the right ways that AI and robotics is gonna, and VR mixed reality is gonna help us you know, make healthcare a lot better. So yeah, don't be a stranger. Happy to chat with any of you offline. Sam's got my info, and so yeah, thanks for having me, and I look forward to the continued dialogue.
All right. Well, we'll see you later. Thank you so much. Have a wonderful weekend. And then thank you all for being on the call. I wanted to call out our winners of the raffle. And I say winners because we had 2 on the whole time. So Jasmahar and Sophia, I'm giving you each a $20 gift card to Starbucks. So I'll email those to you. For Monday's call, I just wanted to share that you do not need to be on until 10:30 a.m. We have another class jumping on at 10 a.m. And it will be a repeat of what you heard on day 1. So you do not need to join Monday until 10:30 a.m. I'll send out an email reminding you, and have a wonderful afternoon, everyone. Have a good weekend.